Alright, so we just covered Genu Varum. The opposite of that here is Genu Varum, sometimes known as bow legs or bow-legged. So if you imagine that straight line 180 degrees, this is going to be slightly over to the angle in that direction of the femur relative to the tibia. In this case, if you could think about how the weight is being shifted over one portion, where do you think the compressive forces are shifted? The lateral or medial compartment? Yes, so this is going to shift the forces of compressive forces to the medial. It's going to add a slight tensile stress or force to the lateral aspect. And at least this is in a static position. Dynamically, it could vary a little bit. One of the examples from an athlete standpoint, Andre Agassi there, he's known, and if you look at his walking, maybe after he serves or when he's coming back from the net, you'll notice pretty pronounced bow-leggedness within him. And sometimes with bow-leggedness, it results in toeing in, and sometimes they nickname that pigeon-toed. So with Andre, as a lot of other people, they have that pigeon-toed aspect, and even a lot of runners at high levels can be slightly bow-legged, and some people think that gives them a biomechanical advantage as opposed to being a Genu Varum type position. Now, on this slide, I did notice that there's the x-ray over here, and something was funny in the x-ray. Sometimes you get these findings in x-rays. Oh, what is that? It's a brown chicken and a brown cow. How about that? Brown chicken, brown cow. Okay, let's zoom out. Okay, there we are. So, looking at the potential x-ray changes for someone with bow-leggedness or a Genu Varum, because you're going to have increased pressure on that medial side, it could cause early degeneration of the medial meniscus, early degeneration of the articular cartilage on the femoral condyle, the medial femoral condyle, or the medial tibial plateau. And as you can see in the image here, you can see how there's a decreased joint space there, whereas the joint space on the lateral aspect is relatively preserved. So one of the things they do for this is this procedure, and you can see post-surgically what they do to restore the joint position there, is they do something called a tibial osteotomy. And because this is the proximal part of the tibia, or the high part of the tibia, they call it a high tibial osteotomy. In this case, they did more of a medial one. So what they'll do is they'll take a little wedge shape out there. That's excessive in terms of the picture, but just so you could see, they take that little wedge, kind of like a little pizza shape, they take that out, and then they secure the bone there. So what that's gonna end up doing is gonna end up taking the tibial plateau and making that seam set down a little bit further. You might have a slight loss of leg length with this of the tibia, but it should be relatively minimal. And then they use the screws in there to secure the lateral aspect of the tibia and make it all aligned properly. So that's a high tibial osteotomy, and sometimes that is a precursor to a total knee replacement. It's a step below that, whereas if they don't want to replace all three knee surfaces, the femoral condyles, the tibial plateaus, and the patella, and that's in a total knee replacement, they might just look at the tibial component. But ultimately, these individuals end up usually having knee replacement. I believe this image here is from an individual in their late 30s from the textbook. Okay, so this next slide talks about something called the Q angle. And so with the Q angle, it's the alignment of the pelvis, which is obviously connected to the femur, in relationship to the entire lower extremity. So we're going to take certain landmarks, and I'll just zoom in on this so you can see this a little bit better. You're going to take a straight line from the ASIS, origin of the sartorius, and you're going to go that right down. You're going to get the mid portion of the patella right there, and then you're going to line that with the tibial tuberosity. Normally this Q angle is around 15 degrees. However, that can vary from men to women. Women tend to be closer on average to about 17 degrees, and men tend to be around 12 to 14 degrees. And just to show you what we're exactly looking at, we're looking at this distance right there. So the higher the Q angle, essentially the wider the hips relative to the knee. So a large Q angle would look something like that. That's, you know, grossly exaggerated, but you get the point that that is a really wide Q angle, and this predisposes someone to, what do you think, a genu valgum or a genu varum? Yes, a Q angle would predispose someone to a genu valgum, and you could think about how that might increase pressure on the lateral aspect of the knee. But more than the knee itself, and we'll talk about this further, it predisposes the patella to track laterally. So there's a nice groove where that patella can go between the femoral condyles, and if there's a larger Q angle, it predisposes lateral patellar gliding, which could be pathological and can promote a lot of pain and other issues. Here's a visualization of that, and the thing I just want to point out is the Q angle, as we measure it, is going to typically be a static test. It may change during landing, during jumping, during running, which is a single leg stance, single leg loading activity. In addition to looking at the Q angle, which is primarily a frontal plane activity, there could be a slight transverse plane motion. So with anteversion, that may result in closed kinematic chain. It may result in an internal rotation of the femur. And if you have that internal rotation combined with the genu valgum, or the increased Q angle, that may cause a torsion, compression, and abduction of the knee, and that may predispose the medial aspect of the knee, and it could cause other implications at the meniscus, at the lateral aspect of the knee, lateral femoral condyle, compressed with the articular surface of the patella. Other things can happen with that, especially over time. And this is clearly showing some tibial torsion as it relates to that as well. So a lot of things can happen with an increased Q angle. Alright, so here we go with genu recurvatum, but time to introduce the cheesy joke segment. So this one is kind of funny. A little bit of a bar joke here. So you have a priest, a rabbi, and a Lutheran minister walk into a bar. Bartender sees them and says, "Hey, what is this, some kind of joke?" There you go. Okay, with that, we'll make this guy leave. So genu recurvatum, and as you could see it pictured here, is basically this hyperextension of the tibiofemoral joint. So where the femur is contacting the tibia, you're going to get a compression that's graded more anteriorly and a tensile distraction more posteriorly. This can result in a plantar flexion deformity, so essentially it's causing the foot to be in a more plantar flexed position, so a lack of dorsiflexion can contribute to this, or a genu recurvatum at the knee could contribute to impaired mobility of dorsiflexion, so it could go either way. But in this picture, I got this from a textbook of pediatric rheumatology, and what's with the kid standing on the glass table? This is straight out of the textbook. I mean, I guess that's how they thought, we'll just take a picture. They already have genu recurvatum, so let's put him on a glass table. But that was from that textbook. So anyway, that is genu recurvatum. Let's talk about some of the implications on this on the next slide. So with the overstretched capsule, this is something that sometimes neurological patients may have due to the weakened quadriceps and ankle mobility. One of the ways that we can correct this, because if the capsule keeps getting overstretched and compromised there, it could result in some problems. One thing here is just by adding some type of wedge or increased heel to the individual. The increased heel is going to push the tibia forwards, and by pushing the tibia forwards, it's going to decrease the extension moment, and that's going to decrease the pressure on certain parts of the meniscus. So if you could think about which part of the meniscus, anterior or posterior, would be compromised in a genu recurvatum. Yes, the anterior meniscus would be under excessive compressive loads, but also the posterior capsule would be on a lengthened or stretched position, and when in a hyperextended position, that may add more stress to the ACL as well as other structures. So that's a quick summary of genu recurvatum. It's something that we look for, and if tried to correct, one of the ways we do that is with a heel lift, but that's primarily with a neurological individual. With someone with intact muscles, we might do more of a strengthening program. Orthotics could also be another way that we look at that. So there we go. So that's the end of this lecture. Hope you didn't mind the jokes too much. Just as a little reward, I got a quick video for you, though.
Uh-oh, guess what day it is? Guess what day it is? Huh? Anybody? Julie, hey, guess what day it is? Oh, come on, I know you can hear me. Mike. What day is it, Mike? Leslie, guess what today is?
It's hump day.
Woo-hoo!
Ronnie, how happy are folks who save hundreds of dollars switching to Geico? I'd say happier than a camel on Wednesday.
Hump day!
Get happy. Get Geico. 15 minutes could save you 15% or more.